Hey YouTube, welcome back to my channel. My name is Dr. Daniel Kaplan, and my mission is to make psychology accessible to all. In today's video, we're going to talk about the concept of intervention, and we'll talk about treatment, maintenance, and preventative strategies. We'll also talk about the different modes of therapy interventions. We'll talk about some cultural factors related to therapy and interventions. And then we'll compare the effectiveness of receiving any one of the therapeutic models relative to no treatment at all. So without further ado, let's get into it. When we use the word intervention, it is a very broad concept which is directed at helping the child and the family adapt more effectively to both their current and future circumstances. And if you were to ask, well, what is the most ideal therapeutic model or approach? I would say there is no singular or best approach to work with children and families. And when it comes to challenges within the family structure, oftentimes there are multiple concerns which require multiple solutions. But our problem-solving strategies do focus on three elements: treatment, maintenance, and prevention. So when we say treatment, we are seeking to correct an action, and we're looking to promote healthy adaptation. For there to be treatment, there must be a licensed practitioner working with a client who is struggling with a condition, and there has to be a series of therapeutic contacts between the two. That's what treatment is. That is to be distinguished from what we call self-help or support groups or crisis hotlines, where they're not necessarily staffed with licensed professionals. So treatment focuses on correcting problems that lead to better adaptation. Maintenance refers to the efforts to increase adherence to treatment through time, right? So if we're building communication in a family and we have a breakthrough, maintenance would be to, okay, let's maintain this, let's continue this process. And that's maintenance. But then there's prevention, which is designed to avoid a problem altogether. So the goal is to decrease the chances of a negative or undesired future outcome. Now, we could talk about the different kinds of interventions, and the intervention can target the child or adolescent themselves, the family, the community, and the culture. So understanding the layers of the social environment. And there are, if you look on the top right, a whole host of interventions one could do, right? So we have a series of therapeutic models and preventative models, and that's all in the purple. We also have a various settings that this therapy can occur in. It can happen in a home, school, it could happen in an agency, outpatient mental health center, and it could also happen in a more restrictive environment, whether it be a day program where the person is there 5 days a week, all the way to an inpatient hospital where the child or adolescent stays there overnight as well. So there's a range of interventions and intervention settings that we have. But I said to you in the introduction to this video, we also have to understand culture and how culture plays a role in treatment. So we want to make sure that we're operating with a evidence-based intervention that is culturally appropriate. And we have the cultural compatibility hypothesis, which suggests that treatment is going to be more effective when it is compatible with the cultural patterns of the child and the family. So we want to be able to make adaptations to our treatment so that it is more inclusive to all clients. And some of these changes or adaptations can be on the surface level or on a deeper level as well. Now, our treatment goals, we can have goals linked to the child, linked to the family, or linked to society. So a couple of the goals we might have related to a child's function is to either reduce or eliminate symptoms of impairment. So that's the negative. We want to remove any form of dysfunction or maladaptive experience. And then on the positive side, we want to enhance or increase social competence and improve academic performance. So these are just a couple goals linked to the child. We also might have goals linked to the family, which is to reduce family dysfunction. So if there's poor communication styles, if there's I don't know, strife between multiple members of the household, we're going to try and reduce family dysfunction. We also might want to increase family support. And if you have a child who is struggling with psychological concerns, one of the biggest issues we see is that sometimes people or families feel like, I don't know where to go with this. I have no support, or I am alone. So if we're working with a family, we might provide resources or outlets to increase family support. Now, related to societal importance, we certainly want to improve a child's participation in school-related activities. And in the case of conduct problems, we want to decrease involvement in the juvenile justice system. These are just a couple of examples of what a treatment goal could look like on an individual, family, or societal level. We also need to keep in mind that our therapy goals and procedures have to adhere to ethics codes, whether it's ACAP or APA. They have, at a minimum, basic ethical standards. So first, we have to set goals and procedures that are in the best interest of the client. We also want to make sure that participation in therapy is voluntary wherever appropriate. There are some rare exceptions where it might be an involuntary process, but typically we want to make sure that the child or adolescent, they're involved in their treatment and it's voluntary. We also have documentation guidelines. So we keep weekly session notes. We also keep treatment plans to make sure that we're moving the client towards a given goal, and we're documenting response to intervention. We protect confidentiality, and this is a tricky one with children and adolescents. At a certain point in time, we are going to have to remind the parents and guardians, I'm working with your child, and they have the right to confidentiality, which means the things that they say in session are protected even from you. And you might say, well, the parents are paying for the therapy, they're bringing the child to therapy, and so forth. But sometimes a child may want to talk about their parents and some struggles that they have, and at the risk of or to protect the risk better of some kind of blowback or strong reaction, we protect the child and what they say. We also have guidelines that require a therapist to only practice in accordance with their qualifications and competencies. If you are not trained in an intervention, you have no business doing that intervention as a therapist. We also determine when a minor is competent to make decisions for themselves. And this is tricky for some parents. I said, and making decisions from a forensic point of view. Each state is going to have their own guidelines on when a child can make decisions for themselves. But that's the state guidelines. We also assess cognitive capacity when it comes to competency. Another thing we have to be mindful is that we avoid any form of ineffective or potentially harmful treatment. Now, that isn't to say that there aren't occurrences where a client is, has a strong negative reaction to treatment. Sometimes there can be harm in treatment, but if you know it's potentially harmful, you have to stay clear of that altogether. And then we have to comply with federal, state, and local laws in order to get licensed in a state. Many states have a legal or a jurisprudence exam to make sure you're familiar with the basic laws of the state, because sometimes that which is intuitive could be a breach of some form of a federal, state, or local law. We don't want to do that. And here are a couple examples of legislative acts that are designed to protect children, adolescents with psychological impairments. Now, if we were to think about approaches to treatment, on this slide, we'll talk about the psychodynamic treatments and the behavioral treatments. But before I get into any individual approach, it's important to understand that a little over 7 out of every 10 clients, or 70 clinicians, 70% of clinicians use an eclectic approach. That is to say, they rely on more than one therapeutic model to do what they do. But if we were to look at the earliest model that has shown up on the scene, would be the psychodynamic approaches. And that comes from Sigmund Freud and Freud's followers. They developed a whole host of treatments related to psychoanalysis. And one of the primary belief is that there's an unconscious factor, or the unconscious as a whole influences behavior, and there can be conflict between that which is happening beneath the surface and that which is available, right? So on a conscious level. So we might have some impulse, drive, or taboo that, according to psychodynamic principles, we push beneath the surface because it's id-based, right? So Freud would talk about personality structure, id, ego, and superego. So we push it beneath the surface because it's a taboo and is inconsistent with what society wants from us. But there is a struggle between the id, ego, and superego, right? So there are conflicts that happen between your unconscious and conscious forces. Now, one of the goals is to help a child develop an awareness of their unconscious factors and how their unconscious drives impact their problems, right? So that is a very, very broad description of psychodynamic treatments. There are a lot. I have other videos that go into psychoanalytic or psychodynamic interventions more specifically. So if you go on my channel, you'll see there are a lot of other videos that do a deeper dive on this. And then I actually have a video series on psychotherapy, and I have a video on Freud and his followers. The second model that came onto the scene were behaviorists. So behaviorists, generally speaking, target that which you can see. So there is an assumption that behaviors that occur are learned, and they're learned through either classical conditioning, operant conditioning, or modeling. And one of the goals is to re-educate the child from a, let's say, maladaptive set of behaviors to a healthier set of behaviors. So there is a behavioral modification paradigm. We also have a cognitive perspective. And the cognitive perspective, we think of Aaron Beck and the concept of cognitive distortions or faulty thinking. And when we develop some form of maladaptive thought pattern, it affects our emotions and behaviors. So, from a cognitive point of view, if we target those faulty cognitions, then we can alter behavior as well. Now, you will hear a lot of clinicians like myself say that we are trained from a cognitive behavioral point of view, and that is that we blend the behavioral interventions with the cognitive interventions. Long story short is we believe that maladaptive thoughts, inappropriate emotional reactions alter behavior. So if we can modify faulty thinking or engage in some kind of emotion regulation, we will get meaningful behavioral change. We have client-centered treatments. This is from a humanistic perspective. So you'll think of Abraham Maslow, or you might think of, in terms of therapy, Carl Rogers. And Carl Rogers talked about client-centered or person-centered interventions. And the focus is putting the client in the driver's seat. They are taking the lead, and we are a facilitator of change. But one of the core features of client-centered therapy is unconditional positive regard, which is the unconditional acceptance of the child. And one of the beliefs that Carl Rogers had was that we acquire conditions of worth through childhood. And the implicit message is that we're only loved or accepted when we behave in accordance with the standards that are set by family or society. So giving unconditional acceptance is reparenting and rewiring the model where a child can learn that they have intrinsic value and they should be loved regardless of their difficulties. Then we have family treatments, which focus on disturbance in family relationships and how to modify the family relationship into a more cohesive unit. So there are different subtypes of family therapy. Some models focus more on the family structure, and power differentials could be part of that. Other models of therapy or family therapy focus on communication patterns. Sometimes we have couples therapy, which might focus a little bit on understanding the difference between behavior and personality, and behavior is certainly more changeable than personality. So these are examples. Now, we also have neurobiological treatments. So neurobiological treatments, they come from a form of brain stimulation or pharmacotherapy, which is medication. And we see that there is an increase in the use of medication. Now, a neurobiological treatment focuses primarily on pharmacological or biological interventions. And what's powerful is if we track children through time, children are more frequently on medication today than they were in earlier generations. And here's an example of tracking from 1987 to 1996. It's just a decade later, and you'll see whether it be medication in general or psychostimulants for ADHD or antidepressants, there is a stronger use of medication. Now, when it comes to using medication to treat mental illness, I believe that the use of medication comes into three categories. There are some conditions where maybe you don't need to prescribe medication at all. There are other conditions where we would prescribe medication as an adjunct or secondary to therapy. So therapy we would try first. If that doesn't work in isolation, we would add on a second treatment, which includes psychiatric medication. And then there's a third category of psychological disorders where even from the beginning, it would be recommended or advisable to use medication as part of your treatment. So if you go to a therapist, a psychologist, the recommendation for medication is not going to be the first line treatment for many conditions. If you go to a psychiatrist, you're more likely to leave with a medication or a script for a medication. So we have to understand how different practitioners relate to mental illness. So we also have this idea of combined interventions. An example is exactly what I said on the previous slide. We can have individual therapy coupled with medication. We can have individual therapy coupled with family therapy and so forth. So when working with children and adolescents, sometimes you have more powerful gains when you combine more than one intervention. We also have community-based mental health programs for children. And we see that children who participate in school-based programs or emotional programs have marked improvement in their behavior and emotional state. We also see that there is a strong emphasis on evidence-based interventions that focus on 5 core principles, right? They're called the principles of therapeutic change. 1 is feeling calm. 2 is increasing motivation. 3 is repairing maladaptive thoughts. 4 is problem solving. And 5 is trying the opposite. So whatever you were doing, if it wasn't working, let's go to the opposite side and see if that works. Now, if we were to look at treatment effectiveness, the bottom line is the vast majority of therapy is effective. And we operate based on best practice guidelines, which are, if you go to the American Psychological Association or other guild organizations, they use a think tank, a group of people who are experts in the field that come up with a series of guiding principles. And they're designed to help practitioners target therapy and be more effective in therapy. They're also designed to help or protect patients. So in developing these practice guidelines, you will see there are 2 main approaches. 1 is a scientific approach, which is the emphasis on evidence-based treatments. You'll see that there's hundreds of evidence-based treatments depending on the condition. But there's also an approach called an expert consensus approach, which is even if the research has not caught up to this intervention, is there a large body of experts who would agree, yeah, this could work? So any kind of intervention that is not yet fully researched, you might rely on expert consensus to fill the gaps. Now, check this statistic out. If a youth engages in therapy, they perform better than 63% of people who don't engage in therapy. Now, across the lifespan, that percentage goes up, which is a client's going to perform better than 75% of people who go untreated. So that's in general. So treatment is effective, and it does improve general functioning of an individual. Now, the impact of a given therapeutic intervention is going to differ based on the problem or condition being treated. So while I say across the lifespan, it's about 75% better than a person who's not in treatment, there isn't a one-size-fits-all treatment approach for all therapies or all conditions, better yet. So that is what I wanted to accomplish in a discussion of therapeutic interventions. I hope you found it useful. It's very broad strokes, understanding what treatment is or therapeutic interventions are, giving you some kind of sense of the role of culture in the effectiveness of treatments, the various subtypes of interventions we can have, and then a little bit about evidence-based practices and practice guidelines. In future videos, when we start to talk about psychological conditions, you're going to see these intervention approaches resurface. Because this series is on childhood disorders, you're going to see some individual interventions, you're going to see some family-based interventions, community-based interventions, and so forth. So keep an eye out for future videos. If you found this video useful, please consider hitting the like button, subscribe to my channel, click the notifications tabs. That'll keep you aware of when I release another video, and you can stay up to date on this video series. But without further ado, I just want to say thank you for being the best part of my channel, and I'm going to sign off for now. Take care.